This episode of the Jerry Pal Podcast is CME eligible.
To claim credit, please go to the CME tab on jerrypal.org.
Welcome to the Jerry Pal Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
We are delighted to welcome Anish Butala, who is a radiation oncologist at the University of Pennsylvania. Anish, welcome to the Jerry Pal Podcast.
Thanks so much for having me.
And we're delighted to welcome Emily Martin, who is a palliative care doc at UCLA. Emily, welcome to Jerry Pal.
It's good to be here.
And delighted to welcome Evie Kalmar, who's a geriatrician and palliative care doc at UCSF. Evie, welcome to Jerry Pal.
Thank you.
So on this podcast, we're going to be talking about what every healthcare provider should know about radiation oncology. But before we do, we always start off with a song request. Anish, do you have the song request for Alex?
I do. My song request for Alex is I Ain't Worried by One Republic.
Why did you choose this song?
Well, I speak, from a physician lens of some of the patients that I get referred. And by the time I'm sort of seeing them in clinic for consideration of palliative radiation, they have a lot going on. It's the symptomatic lesion that I'm sort of discussing with them, but many other things in their lives as it relates to their advanced cancers. And so we take on the mantra of one day at a time. And I thought this song fit that sort of mantra really well of I ain't worried about everything right now. We're just going to focus on, what we're going to discuss. And so I thought this song fit that well.
Great.
I don't know what you've been told. The time is running out, no need to take it slow. I'm stepping to you toe to toe. I should be scared, honey, maybe so. I ain't worried about it right now. Keeping dreams alive, 1999 heroes. I ain't worried about it right now. Swimming in the floods, dancing on the clouds below. I ain't worried about it.
Excellent. Thank you, Alex.
That was fun. Anything where I get to whistle is a great song choice, future guests. I love whistling. It's a lot of fun.
I can't whistle on command. It just blows air if I even think about whistling on command. So well done, Alex. Evie, I'm going to turn to you for the first question. You were the person that instigated this podcast. You want to do a podcast on radiation oncology and radiation therapy. Why?
Yeah, great question, Eric. This is something I've been grappling with a lot. I, as a palliative care doctor, see patients who often get referred to radiation oncology from their oncologist and kind of come back and get told, this is a good option, this is not a good option, this is what it would involve. And there was one particular patient that I had a couple months ago who had squamous cell carcinoma of the base of his tongue. He, unfortunately, the disease was progressing. He was having more pain, more dysphagia. And radiation was offered. It was offered, I think, daily for multiple weeks. And just as I was kind of getting to know him and work with him to think about what would make most sense, I was just really curious, what would radiation do for him? It was a huge amount of time, a lot going on. And so I just wanted to learn more, make sure that as a palliative care doctor, I knew what I needed to know to be able to support this patient and other patients in really considering the risks and benefits of radiation.
Yeah. I got to say also as a geriatrician, I see a lot of people who've had radiation therapy and maybe a couple of years later, maybe they have some, stranger symptoms. Is it late toxicity, dysphagia symptoms, especially in people with head and neck cancer? And thinking that through, it's so common, but we don't get taught a lot about it all. Anish, can I ask you why you went into radiation oncology?
Yeah. So it's a good question. Thank you. I was really fascinated not only with the medical side of things, but some of the physics and mathematics that went into radiation therapy planning. And as it speaks to this podcast, I found that radiation oncology also offered me the ability to treat patients with palliative intent treatment, both adults and children, and allows me to sort of treat every area of the body and focuses on anatomy. So just sort of having that unique blend of anatomy, technology, palliative intent, and just every sort of age group really drew me to the field.
Oof, physics and math. That is not why I went into medicine. And Emily, I got to ask you, you're a palliative care doctor.
Mm-hmm.
You're part of the Society of Palliative Radiation Oncology. You were the current president, past president?
Past president as of January 1st.
How did you get interested in this as like part of your academic career?
Yeah, it's a great question. I knew I wanted to do palliative medicine pretty early, even in medical school, and I was particularly drawn to the cancer patient population and really thinking about that integration into standard care. And there were a number of opportunities to be involved in medical oncology and doing medical oncology rotations as a medical student, as a internal medicine resident. But radiation oncology was really more or less like a black box. Like there really was very little. They had a different like health record system, so they weren't documenting. I didn't know where they existed within the hospital. We would have patients who would go, I didn't really know, similar to what Evie was talking about, how to provide any sort of anticipatory guidance or to know what to expect. And so in residency, I started to seek out opportunities to kind of learn more because that seemed like a really integral element of taking care of patients who have advanced cancer. So I ended up trying to do a rotation as a resident, wasn't able to because there was really no system for that. But in fellowship, early in fellowship, was able to do essentially like a sub-I in radiation oncology, which was really challenging because I didn't understand the first thing about it. But it was a really good experience. I would say possibly even transformative in the context of seeing how many opportunities there were for collaboration and bidirectional education and how many potential ways radiation could help patients and how little that was well integrated into my training. And so that's sort of where it all started. And I'm a little bit of like a radiation oncology groupie in that regard.
You actually created things like a curriculum for hospital medicine fellows in radiation oncology. How much do palliative care fellows and in general doctors need to know about radiation oncology?
I think there are key points that I think are really important. The content, I think, is probably less important, though, than the awareness of the potential and the overall specialty and thinking about it as one of the possible options for patients and then having those communication channels so that they can coordinate with their radiation oncology colleagues.
Anish, do you feel like we send people to you too late or not at all? Or do you feel like we're doing pretty good from a radiation oncology perspective?
I would say, sort of echoing what Emily was just referring to, is education is key. And sort of a few years ago, we would sometimes see referrals a bit later than we would have liked. But now that, at least at the University of Pennsylvania, the radiation oncology department is sort of well integrated into the cancer center here. And we have a really strong relationship with the palliative care team and even the internal medicine residents whom we give talks to. We are seeing, referrals at an earlier time point, especially at a point that I feel that I can really help a patient. So I think education is key. And if that's the case, we often see patients at the right time.
Yeah. Go ahead, Evie.
I just had one quick question about that, Anish, where we work at the VA. We don't have radiation oncology, so everything kind of goes through the oncologist. Mm-hmm. Is it normally the oncologist who's making the referrals to you, or do they come from people outside of oncology?
So the vast majority of the referrals to my service come through a nurse navigator or a medical oncologist. But there are times that a primary care physician or an internal medicine physician may make the referral. But in my practice, it's usually from another oncologist, typically a medical oncologist.
Do you ever get it from a hospice agency?
So usually the patients are not enrolled on hospice care when they're referred to me. Usually it's sort of a discussion about, can we provide palliative radiation before they transition to hospice?
Yeah.
I have had a patient that was sort of experiencing, we'll talk about this, I'm sure, but symptoms from a specific lesion. And there was discussion about whether he or she could come off of hospice to receive the radiation and then go back on. So there's certainly collaboration that's possible, but not typically from the hospice agency.
Emily, we always think about like these radiation emergencies. but I don't think a lot of hospices use radiation oncology therapy. Is that your thought too on this?
Yeah, I mean, I think I actually was going to ask the same question that Evie was, just in terms of the referral pathways, because I think that there is really a missed opportunity to create some of those other channels that would at least open up the discussion, even if it's a discussion that is involving the primary care physician, the geriatrician, the medical oncologist, the surgical oncologist. I think that there's a real opportunity to have more of that team-based sort of approach in thinking, and so that everybody sort of knows when to loop in certain specialties and when that might be a good discussion to have. I think in terms of the hospice, I was really fascinated to learn that radiation, based on Medicare guideline, really is very appropriate and very much falls under the hospice benefit. But I think where it ends up causing problems is just if they're going to have many sessions, transport to and from, and just the overall cost, that can be essentially not feasible for the hospice. So if it's part of a discussion as part of the plan of care as the patient goes and is enrolling in hospice, that shouldn't be a barrier. It's just, I think, emphasizes the use of fewer fractions and really making it very clear that this is intended for palliation of symptoms.
I would love to hear more about cost later, because I'm so curious about that. But I was wondering if we could take a step back and just really basically, Anish, talk about what is radiation? What is the goal of it? What do patients do when they come to radiation? Just so that we can all be on the same page about what it is our patients are going through.
Definitely. So radiation is sort of one component of the overarching model of cancer care. Obviously, the other two are surgery and systemic therapy can be chemotherapy, immunotherapy, et cetera. And then there's radiation therapy. Radiation is the delivery of focused ionizing particles or ionizing photons that damage DNA that attack cancer cells specifically. We can think of radiation in sort of two buckets. One is the curative type of radiation for a cancer that we are trying to eradicate or induce a patient into long-term remission. That's typically the radiation that you hear about that occurs over the course of multiple weeks with daily fractionation. It can be up to 4, 6, 7 weeks of treatment to a primary tumor. As we think about palliative radiation, which is the other bucket, these are the types of treatments that are delivered in a quote-unquote hypofractionated manner or limited number of fractions. Usually it's on the order of 1 to 5 fractions, sometimes up to 10 treatments. And, the goal of palliative radiation in particular is to help alleviate symptoms or address a problem before it may happen. And that's sort of the prophylactic side of palliative radiation.
And what exactly is a fraction? Is that just a divided dose?
Yeah. So the reason we use the word fraction, it's a fancy word for treatment. And, over years of sort of studies, we know that giving all that dose up front is unsafe for patients. And so we deliver the total cumulative dose in what we call fractions or daily treatments or every other day treatments or once weekly treatments so that normal tissue can repair in between the treatments and the cancer cells can get damaged. And we know that that's how we can sort of minimize side effects of radiation as well.
And maybe I can just jump in from a non-radiation oncologist perspective. Something that was really helpful for me to understand is that, radiation doesn't not damage, I guess if I can use a double negative, normal tissues. And obviously, there's a real focus on trying to have as targeted of a treatment, and there's a lot of effort at that within the field. But even within trying to target the cancer, the radiation has to go through the skin and the immediate structures, and so that's important, I think, for palliative physicians, geriatricians, primary care physicians to know, because it means that the symptoms that you can often expect are localized to the area that they're getting radiation. And you can kind of anticipate what symptoms they may expect, whether that's either short-term or long-term. But it also means that the radiation oncologists are trying to think about that balance of how do they selectively damage the cancer cells while allowing the healthy cells time to recover. And so I think that's sort of the balance that often, and again, Anish, correct me if I'm wrong, but that's sort of the balance that goes into kind of dose constraints and really thinking about how many fractions and what overall cumulative dose should be administered for that particular disease.
Yeah, so I totally agree. There's many different ways one can approach treatment, from number of fractions to the type of treatment modality we choose. But I would like to go back to the side effect profile that Emily was referring to. And so as opposed to systemic therapy, which, goes all the way throughout the body, so patients can experience sort of a myriad of side effects that may not be specific to the lung cancer that's being treated. With radiation, it is truly a localized treatment that's directed to the tumor, the lesion that specifically is causing symptoms. And so when I'm treating, somewhere in the lumbar spine, for example, the bowels sit right in front of that area. So I am counseling patients on the risk of nausea or loose stools, depending on the treatment modality that's used. But I'm not typically talking to them about shortness of breath or painful swallowing or dry mouth, just based on the location of the lesion. So I think that's helpful for referring physicians to understand, is that depending on where the lesion is, that's sort of what guides my discussion on radiation-related side effects.
And I want to go back to what Evie asked too, because so you have the initial conversation with the patient, then I always hear like there's simulation, and then they get the dose. What the heck is happening in between the time you first see this patient, this simulation thing, and then them actually getting the dose?
Yes, great question. So that was sort of the next topic. So this is the part of radiation oncology that can be that black box where you're not sure what's actually happening. But the sort of process and procedure for radiation is sort of like a process map. So you have the consultation. The next step is that simulation that you're talking about. And really what that is a fancy word for a CT scan, maybe a CT scan and an MRI or some other imaging on the day of. We call it a simulation because it is a simulation of what treatment position the patient will be in during the course of their radiation therapy. So that might mean laying flat on your back with your arms up over your head, arms down by your side, arms crossed. And what our therapist will do is sort of create or use immobilization devices and take photos and document carefully how the patient is positioned on the table, so that it can be replicated on the treatment machine. Now, the question many people ask me is, they just had a diagnostic CT scan like 3 days ago. Why can't we just use that? Well, I will say we have advanced significantly as a field, and in certain populations we can use the diagnostic imaging, but we'll reserve that for another discussion. The reason that we cannot use that is the bore of the diagnostic CT scan is rounded, whereas the CT scan is flat in the radiation department. And that allows us to do some more accurate calculations for the dose that's deposited. And it allows us to use the immobilization devices. So there's some specific things that we do at simulation that is not as easily transferable from the diagnostic CT scan. So from the simulation, the patient goes home, the physician and the physicist and the dosimetry department put together a treatment plan, and then the patient comes back for their actual fractions or their actual treatments. And so that's sort of the stepwise process.
And when do they get the little tattoo marks? Is that in the simulation?
That's that simulation, exactly. So that's the immobilization. That's when they make the immobilization and they put the tattoos to sort of use those as a reference on the treatment table.
So I'm guessing part of that is there are some people that probably are not great candidates for this, especially people who can't sit still. Is there anything else that you would think about? Like, I'm not sure about this, besides the cancer itself.
This is where it's so critical to have, one, a conversation with your referring physician, but two, a very close relationship with potentially the palliative care physician or the individual who's sort of managing their pain, because the simulation itself can be 20 to 30 minutes of lying in that specific treatment position. If the patient has to keep their arms up, that could lead to shoulder pain or pain in other locations. So we need to sort of have a discussion up front about how we're managing the patient's pain. Sometimes individuals have lung tumors that make it difficult for them to breathe. So we need to manage how they're going to lie flat or slightly elevated in order to get them through both the simulation procedure as well as the treatments. And so, on the inpatient side, which I see a lot of inpatient consults here, a large portion of what I do before they even come down to my department is making sure that they would be candidates for the simulation and treatment for the reasons that I described.
I think that's a really important point also from the palliative standpoint, because there may be concerns or there may be nuances in terms of the patient's ability to withhold a certain position or a certain degree of anxiety or confusion or whatnot that might make this particularly difficult, if not, really impossible. And there may need to be adjustments in the pain medication, the management of patients, kind of similar to patients who have a really hard time going through an MRI or whatnot, right? There may need to be a particular plan for that scenario. And when patients undergo the CT simulation, that usually will give you a pretty good sense in terms of how do they tolerate that, and was that okay? Did their pain management last throughout that entire session? A lot of patients aren't used to being in certain positions or laying flat on their back on a hard surface, or even kind of the masks and stuff that they need to use for head and neck can be extraordinarily anxiety provoking. And what you don't want is to have symptoms that are not well managed during a session that they then say that they don't want to go back and complete the treatment because it has created a sort of an association or such a negative, it's been such a negative experience. And so I just think that there's a real attention to making sure that the symptoms are well controlled for patients in those early sessions.
I can't remember a time where, as a palliative care doctor, the radiation oncologist called me about what happened at the radiation oncology center that we send them to. Evie, can you?
No, but I also think that speaks to kind of this liaison through oncology. I feel like I don't have that direct channel that Emily was describing of communication between me as a palliative care doctor and radiation oncology.
Does the radiation oncologist ever manage some of these symptoms? I'm guessing they do. Like, what's the role of the radiation oncologist as far as managing and palliating symptoms?
I would say to a large degree, I am involved in the management of the lesion that I'm treating or I expect potential side effects from. In our practice, I would say you will see dexamethasone or other steroids used more liberally in the radiation oncology practice. It is not only helpful for pain relief, but also for patients that we're seeing for spinal cord compression or brain metastases with vasogenic edema could help ameliorate some of their neurologic symptoms. So that's something that we commonly prescribe here. And then, more sort of basic pain management measures we're relatively comfortable with. But of course, as we get into the more nuanced, complex pain management, pain management discussions, we are, of course, collaborating and relying, on our supportive oncology and palliative care colleagues.
Does your use of steroids change at all now that we're using a lot more immunotherapy? Like, is that part of your equation?
That's such a great question. So yes, one of the big questions or considerations I'm always keeping in mind when a patient may need dexamethasone or other steroids is what is their systemic therapy regimen? And if they're on an immunotherapy, I try to use an alternate medication that may help their symptoms. And if that's not doing the job, then I reach directly out to their medical oncologist to discuss a short course of steroids in combination with their immunotherapy. And usually by the time I'm making that phone call, the medical oncologist understands that, hey, this is sort of a situation that we need to deal with, despite the potential downsides to it.
Yeah.
I think this kind of also comes back to this idea of role and scope of practice. And, one of the things when I did my sort of immersion into the radiation oncology world during fellowship was that, the training program really didn't have any dedicated education on pain management or, any symptom management. It was very focused on the technical aspects of delivering palliative radiation. That was sort of the scope. Things have evolved and changed, and now there's some very, very general guidance from ACGME in terms of at least mentioning palliative care as something that they should sort of be exposed to, right? Like it doesn't outline exactly any real topics that need to be addressed or the content. But I think that was really eye-opening for me because, there was a general discomfort in knowing what to do beyond kind of first-line management. And I do think that there are situations where patients may need more complex interventions just to get them through the treatment, and that's kind of a real opportunity for some of that bidirectional education and to make sure that there are some open communication channels and so that there is a plan. I mean, it's a tremendous, missed opportunity if a patient goes down, can't get their radiation, doesn't complete the session, and it could have been something that could have been avoided.
I was going to say, I want to hear and talk more about kind of what to expect and what to do after radiation finishes or while it's happening. But I wanted to step back and just ask, who should we be thinking about radiation for? Who's the ideal candidate? Or what are the little triggers in our mind that we should say, I wonder if we should think about referral to radiation oncology?
That's a great question. And I think it's one of the key discussion points of this episode. So palliative radiation has a long track record in the literature of helping for a number of indications. Pain specifically is a big one, particularly for lesions that are bone metastases that are localizable that we can treat. We have data that shows that up to 60 to 70% of patients have some degree of pain relief from as little as one treatment of radiation. So that's a big reason for referral. Bleeding or hemostatic radiation is another reason that we think about referral. So this can be GI bleeds, GYN bleeds, bleeding from endobronchial tumors. If you're seeing a patient, as little as one to five treatments can help curtail some bleeding. Patients often develop obstructive type symptoms from the mass effect of their tumor, as we know. So this could be in the GI tract, it could be vasculature, it could be in the airway, and radiation can help cytoreduce any of these lesions to help improve organ function. So that would be a good reason if there's a localizable lesion that you're wondering if we could help shrink it to help ameliorate symptoms. That's a big reason. And the big one, and I'm pointing to the spine back here, is any neurologic symptoms related to spinal cord compression or disease in the brain that's causing symptoms. Radiation is a really helpful and tried and true modality for those types of symptoms.
And that kind of leads to the radiation therapy emergencies, right? We think about spinal cord compression, brain edema, superior vena cava syndrome. Are those the three that you think about?
Yep. So spinal cord compression, brain herniation. In that case, we're usually involving neurosurgery, leptomeningeal disease, hemorrhage. So sort of ongoing bleeding that's not responsive to other therapies, and of course, airway obstruction. So those are the kinds of 2 a.m. phone calls that I get when I'm on call usually.
And for those, does everything just condense as far as consultation, simulation, and dose? Is it just boom?
Yeah. So we kind of do everything on the same day. We'll see the patient in the morning, get them simulated, and try to deliver treatment on the same day, depending on how urgent the case is.
Emily, from your experience as a palliative care doctor, when do you see the most use of radiation therapy?
I think no question in the setting of bone metastases and such. That's kind of bread and butter from the standpoint of the general patient population.
That's mine too. I got some lightning questions. Is it okay if Evie and I threw out some lightning questions? I'm going to put you on the spot, Evie. I'm going to start off because I'm going to use Evie's question from the start. Bony pain. Let's talk about bony pain. Single fractionated or multi-fractionated? Hypofractionated? How shall I even describe it? One dose or many?
Good question. So multiple randomized trials have demonstrated the equivalence in terms of pain relief between single and multi-fraction regimens, so much so that a meta-analysis basically said we shouldn't study this anymore. So for uncomplicated bone metastases, meaning there's no spinal cord compression, no pathologic fracture, either offer equivalent pain relief with some caveats in terms of increased retreatment rates in the single fraction patients, meaning there's a little bit of an increased risk of down the line, they may need another dose of radiation.
Why then do so many people get multi-fraction doses still?
So there are patients for which multiple fractions, which may mean a higher dose, may be beneficial. So in my practice, I typically recommend multi-fraction or higher dose regimens for patients who have extra osseous extension or complicated bone metastases, which most of the data surrounding equivalency of pain relief is in this sort of uncomplicated bone metastasis population. But once you have things like spinal cord compression, extraosseous extension, neural element pain related to the disease, sometimes it makes sense to offer a little bit of a higher dose. So that would be the reason that you might see that.
And how quickly do you see the effect?
So effect of the radiation itself.
Mm-hmm.
Yeah, so I counsel my patients that it can take a few weeks to see sort of the full effect of radiation. I think of it as sort of a bell curve. I have that occasional patient that gets pain relief after the first few treatments. And when they tell me that, I say, well, I wish all my patients were like you, but this is extremely rare. It's usually 4, 6, 8 weeks out as I see the maximum effect. And then the tail drops off.
When's the earliest that you start to see effect?
Like I just mentioned, there's the rare patient that has it on treatment, but the earliest is typically 1 to 2 weeks if we do see it.
Typically 1 to 2 weeks after you start to see a meaningful effect.
And for bony mets, do you use a lot of steroids or not? Like, I've always been confused when you use steroids for bony mets because it seems to help a lot with pain. I realize that there's now issues with certain cancer therapeutics, but how do you think about that for steroids?
So there are 2 major randomized trials that were done with this specific question in mind. One major randomized trial demonstrated a reduction of the incidence of pain flare with prophylactic steroids, and another showed a delayed incidence, but not necessarily a reduction in the rate. All that in mind, I first say there's no clear-cut guidelines in how we use steroids, but in my practice, I counsel on this risk of pain flare, which we haven't talked about yet, but I think it bears mentioning. That's where the radiation itself causes an increase in pain and during or shortly after the radiation treatment. And it can be mild, can be moderate increase in pain, or in rare cases, it can be a severe increase in pain at the treatment site. So to minimize the risk of that, I put patients on a dose of 8 milligrams of dexamethasone with a 4-day course thereafter to reduce that risk. There are some, analyses that have been done to predict who's going to get a pain flare or not. But in my mind, patients with certain types of cancers like renal cell carcinoma, patients who have baseline pain and who have soft tissue extension of their tumors are ones that I think about steroids ahead of time because of their elevated risk of a pain flare. But it's always a physician-patient discussion because, it has side effects, particularly the insomnia and the agitation that we can sometimes see with the higher doses.
How do you think about the durability of the effect?
It's a great question. There was a trial published in the JCO a few days ago that looked at a technique called SPRT, which is a high dose of radiation and with sort of millimeter precision versus what we use the term of conventional radiation, which is sort of that lower dose per day, which is what's been there for decades. And when we think about sort of the durability of the effectiveness of radiation, typically local control or tumor control is tied to the total dose that we use. And so if a patient has a more prolonged life expectancy, I may use a higher dose of radiation to control that tumor. But the reason I bring up that trial is one of the discussion points with some emerging data is that this higher dose of radiation with SBRT may not induce pain relief more quickly than the conventional lower dose regimens, but it may induce longer term durability. And so we sometimes see higher complete pain response rates at 3 months and 6 months with this higher dose radiation compared to the conventional arm, which may be just a few months.
And can you re-irradiate?
Yeah, these are really good questions. Yes, so you absolutely can re-irradiate. That's a large portion of my practice, and I give credit to the wonderful medical oncologists who have developed all these systemic therapies. Now patients are living so much longer that they're coming back to my clinic after I've treated them with radiation. So there's a number of sort of guidelines out there, but the general answer is yes. We just have to wait a sufficient time to allow for maximal tissue recovery. So for example, when I'm treating over the spine, I typically like to wait 6 months to deliver a second course of radiation to allow for maximal spinal cord tissue recovery and minimize the chance of myelopathy or spinal cord injury with a second course of radiation.
And that's to the same spot or to any spot in the spine?
Yeah, great question. So to the same spot. If I treated, let's say, T3 and then T10 needs treatment, that doesn't require 6 months. It's really if you're re-irradiating over the same portion of the spinal canal.
And I think this is important in the context of something you said earlier, Anish, which is, single fraction versus multi-fraction for uncomplicated bone mets and the rate of, reirradiation, and thinking about that as a sign of either, treatment failure or, limited durability, but also that clinical practice has evolved such that our understanding kind of as a medical system of what the body can tolerate and the overall benefit versus risk ratio for reirradiation has evolved such that, there has been a lot of hesitation about reirradiating a site if there has been multiple fractions that have been given to that site. And so if it's, I guess, more leniency or there's been more comfort, I guess, reirradiating a site that has one. So I think that's an important piece just in terms of thinking about the durability. I don't know, Anish, if you can speak more to that from the radiation oncology practice standpoint, but that's been something that's been highlighted to me.
Yeah, I would definitely say from a palliative care and geriatrician standpoint, if a patient is reporting symptoms at a site that's been previously radiated, I would not say that that's a contraindication for a referral. I would say meet with your radiation oncologist because at least over the last 10 or 20 years, our treatment techniques have evolved so much that, some patients are even receiving, one of my colleagues curbsided me about treating an area for a third time. And that's sort of pushing the boundaries, but these are the types of discussions that I'm even having now of not only the second time radiation, but even a third sometime.
So they have a really bad cancer. Maybe they're dying from it. What do you most worry about with reirradiation?
Depends on the site that we're retreating. So we group radiation toxicity, as with any sort of, we group them into acute and late side effects. When I have a patient that's approaching end of life, I focus much more heavily in my conversations on the acute side effects. So if I am thinking about retreating a thoracic spine lesion, I'm heavily counseling them on the risks of pain flare because that's very noticeable immediately during and shortly after radiation, and the risk of esophagitis. There are, of course, longer-term risks of fracture and myelopathy, but I always focus on what would be most pertinent to the patient at hand. And it just goes back to our earlier comment that sort of the side effects of the radiation we're giving is localized to the lesion in question. So in that example, it would be what's most pertinent to the patient in the short-term setting, which would be esophagitis and pain flare, and then it could depend on what I'm treating.
And Emily, from a palliative care perspective, what side effects should the palliative care doc, any doc, should know about and think about how best to treat?
Yeah, I think mucositis, proctitis, dermatitis, there's a lot of kind of inflammatory responses that can occur. And so having a good understanding of those, I think another one that is maybe not a side effect per se, but it's sort of in some ways just being aware of the overall time course so that if somebody is anticipated to have lower overall opioid requirement need, from as their pain improves after radiation, just to be thoughtful about that. Sometimes we'll have patients who are really needing a kind of a higher dose, but always keeping in mind of what was the timing of their radiation and how do we make sure that we de-escalate as appropriate. And so that's something that to be thoughtful about. Also, if there's the need for de-escalation of dexamethasone, because there's definitely been times that it has been started at some point in the patient's course and it has been continued.
Yeah.
Definitely. So I really liked Anish, the comment about, ordering it for a certain number of days, but I think sometimes there's just a default. And so being thoughtful about any other side effects that patients might experience from just prolonged use.
Yeah.
I have a follow-up question about that. I find radiation mucositis one of the most difficult symptoms to treat. Any pointers, Emily or Anish?
Yeah, it's really challenging, and it creates an element of, people's time course is different. Sometimes it can be pretty severe, but short-lived. Sometimes it can be a pretty durable symptom, especially if they're having a long treatment course for a head and neck cancer, and where there's kind of an ongoing use. I think in addition to systemic pain control and just appropriate management from that standpoint, there are some topical solutions that can be helpful. I think you hit a point where any sort of swish and spit or swish and swallow or anything, is just too painful in of itself, right? So then it kind of takes us back to just basic mucositis management and making sure you have systemic opioids on board. But yeah, I think that's an area where there's no real easy solution. Some things that work really well for one patient, may or may not work for another. But I know there's been a lot of looking into like doxepin and such just to see kind of what might be effective. I don't know, Anish, if you have other experience.
Yeah, so I would agree with that. The topicals, the potential rinses, but the other thing I would guide is to try to loop in your nutrition or dietitian team if you have one available. They are so helpful in ensuring that those patients in particular, the head and neck cancer patients, receive appropriate nutrition and maintain their weight throughout. But yeah, it is a challenging side effect, and usually it's sort of the things that have been mentioned.
I was going to ask kind of a similar or related question. When should we be contacting radiation oncology after treatment? Like, what are the things that make us say, oh, we should loop back in with the radiation oncology team?
So when you yell in the middle of the night, why didn't they call me before?
Yeah. So I could list 15 different things, but here's the answer that might bucket everything is if the patient is having symptoms in a previously radiated area or something that could be related to that, please just loop us in. If it's a lung lesion and the patient's, having shortness of breath or cough or some new bleeding as they cough, those are things to just notify a radiation oncologist. Same thing with a GI site or a bony site, new pain at a site that was previously treated. We want to know about it because we can help guide the workup. Usually that will include, the physical exam, but also the type of imaging that would be helpful for us to have to guide what would be next steps.
Do you guys also, for bony pain, is it radiation oncology that's deciding also on bone targeting radioisotopes, or where does that fit in?
So radioisotopes certainly within nuclear medicine, but it's a burgeoning aspect of the radiation oncology practice, so much so that there's sort of work groups surrounding it. So depending on where you are, the radiation oncologist is prescribing it versus the nuclear medicine doc, and it's just institution specific.
And when should we consider those?
That is certainly within the purview of the referral from the medical oncology team, but certain types of cancers, particularly prostate cancer, is one that typically merits the discussion with the radiopharmaceutical administrator.
So if it's spread to like multiple sites, potentially.
Metastatic prostate cancer, that's right. Yep.
I have a question about a more conceptual question. There's this issue that many patients who are receiving chemotherapy that is quote unquote palliative, which is, often taken to mean any chemotherapy that's not curative intent. Those patients nonetheless think that they're getting the chemotherapy with curative intent. And I wonder if there are similar misconceptions around patients who receive radiation therapy.
Yes, it can
palliative, so-called. Do you use the term palliative radiation with patients? Do you use it with each other? And what does that mean? And do you worry about these misconceptions?
Yes. So just to start this discussion, my specialty is within palliative radiation, patients with advanced and metastatic disease. So I find it's probably a little bit more commonplace for me to have this discussion. But when I have a patient sitting in front of me, the first thing I say is that the intent of this treatment is to help your symptoms. I never sort of say that it's going to get rid of your cancer, but that's often the question that the patient asks me next is this going to get rid of the cancer? And then I go into a discussion about why the dose that we're using in the palliative setting, which is usually much lower than the curative setting, will not sort of get rid of their cancer, could help keep it at bay for a short period of time. And that is sort of helpful. I don't always use the word palliative unless it's a patient that is very medically literate or has that sort of background. That would make sense. But I think sort of using that targeted language of helping your symptoms helps frame the discussion for the patient.
Thank you. Emily, any thoughts on that or experience?
Yeah, I mean, I think this is a really important question because I think that a hospitalization, progression to a new line of systemic therapy, a new treatment modality, going to a radiation oncologist is a good time point to sort of check in with the patient and understand what their illness understanding is, make sure that they understand the intent of treatment and such. And I would say not infrequently do I see patients who have a misunderstanding about radiation similar to their kind of systemic treatments. And so I think that it's an important point to make sure that patients are making informed decisions and that that conversation is happening, and that really that even just the referral to radiation for something new is a good trigger for that, to just check in and to make sure that those conversations are happening. The patient has the information that they need. And maybe that is a larger conversation that also continues in other contexts. But I think that radiation oncologists have a really key role in that consultation.
Evie, I'm going to give you the last question.
Gosh, I have so many, but I think the last question that's on my mind, as we talked about it earlier, is cost. We talked about kind of risks and benefits of the treatment. And I just was wondering if you could speak a little bit about cost. Do patients tend to pay a lot for radiation? Like, what should they be expecting in that respect? I'm sure it depends with insurance and where you are.
Yeah, usually the insurance company will cover the cost of the radiation therapy. There may be copays or things like that, but we in our department are obtaining insurance authorization before the patient even gets on the table. So it's not typically something that the patient experiences. That being said, some of our more advanced technologies, as they are more expensive, we do encounter some pushback from insurance companies, and it may require phone calls, letters of medical necessity, et cetera, but not typically something the patient directly experiences.
Is that like the difference between like a stereotactic, or what do they call it again? A stereotactic?
SBRT.
SBRT.
Yeah, that's right.
And maybe just one other comment on that is that, per fraction and per treatment increases the overall cost. So there is also that element of, in thinking through, and that's why, a hospice agency may be able to accommodate a single fraction. But if they have like a 10 fraction regimen, that's going to be exponentially more expensive.
Well, Anish, I guess that my last question then to you is like, for the people who are listening, let's say we have a patient who lives kind of far away. They're in hospice, hospice is getting like $160 a day. Are there things that the providers could say to help encourage single fraction versus multi-fraction that would work well with the radiation oncologist?
Yeah, I think the data surrounding the equivalency of single versus multi-fraction is known and hopefully known throughout the field. And so if the referring physician or provider were to say, hi, I have a patient with an uncomplicated bone metastasis that may need a fraction of radiation for pain relief, that might sort of move things in that direction.
Anchor them from the start. Behavioral economics right there. We're going to nudge them to the single fraction.
You got it, yeah.
Well, I want to thank all three of you for coming on. Before we end, I think Alex is going to take us home with, what's the song title again, Anish?
I Ain't Worried by One Republic.
I Ain't Worried.
I don't know what you've been told, but time is running out, so spend it like it's gold. I'm living like I'm 9 zeros. Got no regrets even when I'm broke. I ain't worried about it right now. Keeping dreams alive, 1999 heroes. I ain't worried about it right now. Swimming in the floods, dancing on the clouds below. I ain't worried about it.
That was great, Alex. Don't worry about it. Emily, Anish, Evie, thank you for joining us on the Cherry Pal podcast.
Thank you so much.
Thank you.
And thank you to all of our listeners for your continued support. We'd also like to say a big thank you to those who've donated more than $250 to the Cherry Pal podcast over the last year, including
Anna Lynch, Deborah and Jeffrey Larson, Krista Mossack, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordowski, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, Paul Amatelli, Brian Castle, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Samoji, Matthew Schuster, Carrie Hagan, and Lloyd Woolstadt.
A very big thank you. And if you too want to donate to the Cherry Pal podcast, please go to the Cherry Pal website and click on the blue or orange donate button.